Thank you for your kind invitation. My topic is which tendon transfer and how I do in massive irreparable posterior superior cuff tear. This is my disclosures. We talk first about irreparable posterior superior cuff tear with supraspinatus and infraspinatus tear and sometimes no functional tear. And I use two tendon transfer, latissimus dorsi and lower trapezius transfer. So my indication of latissimus dorsi transfer is supraspinatus tear and infraspinatus tear, irreparable, and the teres minor is good, is functional. I do a mini invasive axillary approach to detach the latissimus dorsi, and I fix by arthroscopy on the great tuberosity of the humeral head. I don't use full arthroscopy described by Laurent Lafosse and Jean Cany. So regarding the fixation of the latissimus dorsi, if you want to restore forward elevation, I fix in the anterior part of the great tuberosities. If I would like to restore active external rotation, I fix to the insertion of infraspinatus on the great tuberosity. So my indication is limited active anterior elevation, weakness, painful shoulder, but you see that the shoulder is not pseudoparetic, and very important is that the deltoid is good. There is no stiffness, and very important is the quality of the subscapularis. So I do MRI, and you see that this is a retraction type 3. I analyze the muscle is atrophic with a fatty infiltration more than 2. And the subscapularis is very nice, is very important this point, and there is no glenohumeral arthritis. So when I operate, always I try to repair the cuff, but in this situation, you see that it's impossible to repair. Sometimes the superior part of the subscapularis, there is a partial lesion, type 1 or 2 Lafosse, and I repair. And more important, if it's possible, I do a medialization or advancement of the infraspinatus or margin convergence. I try to do always a partial repair. So this is the axillary approach, very short incision, 5 centimeters. This is the portals to fix the latissimus dorsi by arthroscopy on the humeral head. When I open the skin, I look for the white aponeurosis band. This is the key point. And after I release the latissimus dorsi from the triceps, from the teres major, from the angle of the scapula. It's very important. And after, to obtain a good exclusion, you see that the exclusion of the latissimus dorsi is very important, because if you fix with tension, there is a risk of avulsion of the tendon transfer. You have to release very far to the angle of the scapula. So you see very well, this is a latissimus dorsi, aponeurosis band, this is the teres major, this is the triceps, this is the deltoid. And the good way to go to the subacromial space is to put your finger between the triceps medially and the deltoid posteriorly. And you put your finger and you look for your finger by arthroscopy. And when your finger is between the posterior deltoid and the remaining cuff, after you do a shuttle relay system to pull the latissimus dorsi in the posterior portal, I prepare the footprint and I fix with 2 anchors the aponeurosis band over the great tuberosities. And you have a very nice contact here, but the distal point is close to the subscapularis if you want to restore forward elevation. I published a series with more than 5 years follow-up, and you see that with latissimus dorsi transfer, you restore more forward elevation, 42 degrees, more external rotation, 11 degrees. The constant score is around 60, and the function of the shoulder is around 70. So all the scores are improved. If it's possible to do a partial repair, if it's possible to do a partial repair, the result is better. And this is a publication in 2017. And you see that the result with latissimus dorsi on partial repair is better than isolated latissimus dorsi transfer. So if you have no teres minor, no infraspinatus, no supraspinatus, I prefer to do lower trapezius transfer. Same, I use a mini-invasive dorsal approach close to the medial scapula. I extend the lower trapezius with a semitendinous or allograft, and I fix to the humeral head at the level of the infraspinatus with arthroscopic technique. So if you analyze the lower trapezius, you see that there is the same vector on same action and is agonist of infraspinatus. Is very, very nice transfer because it's the agonist transfer. And when you do external rotation, you have a activation of the lower trapezius. So the excursion is close to the infraspinatus, but less strength. So this is my indication. There is a lag sign. There is a dropping sign. There is no active external rotation. The shoulder is not pseudoparetic. You have a good forward elevation. But if you have forward elevation more than 90 degrees, you have a Hornblower sign. Regarding the imaging, you have no supra, no infraspinatus, and no teres minor. Atrophic muscle and fatty filtration more than 2. We have a good subscapularis. You have no arthritis, of course. The same during the operation. I try always to repair the cuff, but it's very difficult in this situation because you have no teres minor, no infraspinatus. Sometimes you can advance the infraspinatus. If sometimes the subscapularis is in continuity, but there is a lesion of type 1-2, I repair the subscapularis. You see, this is the incision to detach the lower trapezius. This is the portals to fix the extended lower trapezius on the humeral head. We use a semitendinous to extend the insertion of the lower trapezius to the humeral head. Is around 12 centimeters. So the key point is be aware to the spinal nerve. And many times I use the nerve stimulator to locate it. I am harvesting a semitendinous tendon. Sometimes I take the semigracilis to have a bigger dual tendinous graft. I fix the first on the infraspinatus level with 2 anchors at the level of the infraspinatus. And I check the tension in maximum external rotation at the level of the lower trapezius muscle. And I fix it with I do a partial repair if it's possible. And very important now, I immobilize the patient in a cast for 6 weeks, the arm close to the chest. So I publish the result of my first 15 cases, and I see that the dropping sign or Hornblower sign is corrected in 100%. When you have a negative external rotation, you have postoperative positive external rotation. You see that it's around 20 degrees. In abduction is around 40 degrees. You increase forward elevation. You have no pain, of course, and the function of the shoulder is around 70%. And the constant score is 60. So my first conclusion is that when you have a massive, irreparable posterior superior cuff tear with a good teres minor, I prefer to do latissimus dorsi transfer. And this tendon transfer improves forward elevation and a little external rotation in abduction 90 degrees. If the result is better, if you can combine with a partial repair of the infraspinatus. And in this situation, latissimus dorsi is a tendon transfer augmentation. If you have no teres minor, no infra, no supraspinatus, I prefer to use lower trapezius transfer because it can improve external rotation more than forward elevation. And if you can combine with advancement of the infraspinatus, it's better for the results. Thank you for your attention. I invite you next year in Paris for the Paris International Shoulder course. Muchas gracias.